Hi guys, this is our third video. My name is Aditya.
And hi guys, my name is Ikansh. As you said, back to our third video.
And as you know, we're doing a series of videos just to introduce the coming people to the UK as to what it is working while in the UK. It's an introduction to what to expect.
So this is our third video, and I hope we've been able to help with our first two videos. In this video, the topic that we're taking up is basically what to expect in the MCH/MEd program. The program typically involves working as an SHO for the first year and then working as a registrar during your second year. The third year, which is set to be optional, is generally as a registrar.
Yeah, and in this video, what we're trying to explore is a little more in detail as to what exactly is an SHO, what are the responsibilities as an SHO, what is a registrar, what are the responsibilities of a registrar, and the groundwork that you will actually be doing in the hospital once you arrive.
Absolutely. The first thing that I didn't know when I moved to this country is what's the full form of an SHO?
Yeah, neither did I. Yeah.
What is the full form?
Well, apparently it's a senior house officer.
I didn't find anything senior about it.
That's true. A senior house officer is the first post that you will be joining through this MCH program in trauma and orthopedics.
Yeah. Even in other programs, but it can happen that in certain pathways where the applicants are not as much and they have vacancies of registrar's post, you might just start off directly on a registrar post. Now, we are keeping this to talk mostly about the SHO and the registrar, and you can take what applies to you. The first thing that we have to do to understand what your duty entails in this is to understand the system. Because we come from the Indian healthcare system, which generally involves doing an MBBS and then a year of internship, and you sit for an all India exam or a state exam and eventually land a spot on one of the postgrad training programs in a particular specialty like a surgery or a medicine or peds and so on and so forth. And then you do 3 years of post-graduation, you come out of that and then do another 3 years of a DM or an MCH. Now, Aditya, do you want to elaborate on how the system works in this country?
Yeah, so it's important to know what the grade of an SHO doctor. So essentially in this country, when you finish your MBBS, what you join in as is called an F1 or an FY1, which is also similar to a foundation year 1 doctor, which is the same as having an internship during your MBBS back home. So in India, an internship program is a 1-year program, obviously, where you rotate in different subspecialties. In the UK, it's actually split into 2 years, which is FY1 and FY2. And that is when you actually complete your internship years and then start applying for an SHO grade job.
Okay, so just to get that right, we do the same time as an MBBS here, but instead of doing 1 year of internship, you do 2 years of internship, and your post reads at FY1 and FY2, which is final year 1 and final year 2.
No, it's a foundation year 1 and foundation year 2.
I stand corrected.
Yeah, absolutely. And that's when you join in as an SHO, which is in some ways similar to joining as a non-ACAT JR back home after finishing your MBBS and internship. In your interim period, you're looking for a job. A lot of people try and do that here as well at the same time.
I think what they call it here is a co-trainee 1 and co-trainee 2, which essentially means the first year and the second year. Now, the time as a co-trainee doesn't really have anything that corresponds to something in the Indian healthcare system, because after your co-trainee 2 year, you sit down for an interview and a whole application process, at which point you're assessed based on an interview, on your CV, on your profile, and everything that you've done and experienced so far. And there's a very objective point-based grading system for it. And depending on how you perform on it at a national level, you land a spot into the specialist training program, which could either be on the medicine side or be on the surgical side. So it's this CT1 and CT2 time where you work as an SHO.
Yeah, so your colleagues in this hospital at an SHO grade who are in the training system would be CT1 or CT2 level doctors, which corresponds to the first year and the second year, obviously. And in these years, what the CT doctors do in this country are they rotate through various subspecialties for 6 months or sometimes longer, depending on their field of interest. a it may be a medical field or a surgical field. When it comes to orthopedics, it's obviously a surgical field. So if somebody is working as a CT doctor in orthopedics, by default, they would also be rotating in other aspects like general surgery or vascular surgery in the entire span of 2 years. And that's the grade which you actually start working here in this country.
So, as he said, you can work through vascular, plastics, or orthopedics. This is just to ensure that people get enough exposure to the different aspects of a surgical side so that people can choose as to what specialty they might like.
Mm-hmm.
Even though it does add 2 years to your training program, I think what it does is it gives you a chance to work for a significant period of time, say about 6 months in a particular subspecialty, to decide if that is what you want to pursue eventually. However, as you're coming in as a part of the MCH program, you would not be expected to work as an SHO in any other department besides orthopedics.
Yeah, so that's 1 year straight off in orthopedics as an SHO grade doctor. How it makes a difference is because back home in India, once you finish your internship, the exposure internship can vary significantly, and then you go off straight into orthopedics in a surgical field, and it is an out-and-out surgical field, and that possibly in some cases might even be the first time you hold the knife in your life. And but what the CT1 and CT2 enables the local trainees over here is to rotate through different subspecialties and get the basics of surgical training right before they enter into a subsequent field of their choice of subspecialty.
And this is the time when the regular trainees here are expected to do their MRCS or the MRCP on the website, and which acts as an entrance exam to the specialist training program.
Well, not an entrance exam, but a prerequisite.
Kind of like a prerequisite.
Yeah.
So now that we've ascertained how this works, you would be required to work as an SHO for the duration of the first year that you're here. Now, the duties that entail being as an SHO is that you'd be expected to cover the patients on the ward, which means going on rounds with your consultants or your fellows or your registrars, ensuring that there's a full clinical, radiological, and blood workups done for the patients. You would also expected to liaise with different departments, ensure that the referrals are followed through, the scans are done.
Yeah, I mean, so essentially you're doing all the groundwork in terms of preparation of a patient. So think of it as in terms of the groundwork that you do in a government hospital where your senior tells you, oh, this patient needs that reference, you need to chase that up, or make sure that this patient has a plastic reference by tomorrow, which a lot of the consultants are keen on getting overnight, obviously. And so these are the things that will be required to do apart from just general basic ward work as a doctor that obviously will include making decisions as to when the patient needs bloods, whether and chase those bloods up, if the patient is going in renal failure or hyponatremia, prescribing fluids, prescribing their medications to the patient in the ward, and obviously being there in the ward throughout the day, and speaking to the patients if they have any complaints and problems, and obviously you have other colleagues as well with you working in the same grade who may or may not be in the ward with you, but then of course if you need to escalate, you need to know that you will be working under a consultant and a registrar. So those are the senior people who will be whom you would be answerable to.
Absolutely, and I think you bring up a very important point, because you'll be working on a ward, and once the rounds are done, you might be by yourself. It often requires you to have more in-depth knowledge on managing certain medical conditions like chest infections, UTIs, pneumonias, reading ECGs and chest X-rays and being able to decipher the blood results to be able to liaise effectively with different departments. Besides doing this ward work, you'd also be expected to help out in clinics. This might or might not be so depending on which trust you work in. For example, the trust that I worked in had me doing fracture clinics, so it was good exposure, but I think, if I'm not wrong, you probably did not have any clinic sessions.
Yeah, so it's important to know that the duties of the SHO are akin to having, you're actually called a junior doctor. That's at the end of the day what it is. So it's very important to manage your expectations when you come here in terms of, so for example, if you're very, very experienced and working in a senior position back home, you're doing arthroplasties and every other day and managing those patients all by yourself or with the team. You have to understand that all that goes away. for an entire year. Absolutely. So you will be doing a very basic work. The amount of actual orthopedic clinical work will be reduced to your ward work and your on calls, which we'll explain further in this video as to what an on call is. Apart from that, obviously there's clinics and operating theaters and everything, but the exposure to those is very variable from trust to trust. So in my experience, when I was working as SHO, we were categorically told that there is no dedicated elective theatre session for us, and we would not be going into elective operating at all. So for the entire duration of the SHO time, I did not attend elective theatres which were dedicated to on my to my rota. If I had to go to those, I had to make them on my own time. Obviously, as an unpaid doctor, and for my own experience, that we have to do so. And apart from that, we did not have any dedicated clinic sessions. I was not seeing patients that are coming to the clinic. It was simply following instructions from your registrars and your consultants, and making sure that the groundwork at the ward, at the level of a reference or communication is done, and the patient is also making sure that the patient is ready as a pre-op for the next day's theatre. And that's one of the essential things that you have to do. You need to make sure the patient is fit from a medical point of view. If you identify a problem, you need to know whom to escalate and how to.
I think those are things you probably learn while you start working here. I mean, my SHO period was slightly different. While I didn't have any designated theatre sessions, I did have some theatre sessions, but these were mostly trauma theatre sessions, and I was usually with a consultant and a registrar. Even though there was some exposure, the hands-on experience was, to be fair, very limited. I also was doing clinics. I often found myself, seeing patients by myself. So in a way that was good, but I think that is where the buck stops with the clinical exposure for the time as an SHO. Besides this, you're also expected to be on the rolling on-call rota. This on-call rota works differently for different trusts. It can work where you're supposed to do long days, or you're supposed to do night on-calls, and this can come as single day duties, every week, or they can come as blocks. This is something which varies from hospital to hospital, depending on how big the department is, how heavy the workload is. But you would be expected to be on the on-call rota, where you would generally have another registrar with you, but you would serve as a first point of contact for any referrals from, say, the ward, from the emergencies, from GPs outside the hospital. In busy hospitals, it can get quite taxing. But the good thing is you're not expected to work beyond 12 hours at any point.
Yeah, it's important to understand. I think if you're working on-site at the hospital, there's a very important rule that disallows you from working beyond 12 hours at a stretch. And that includes your coffee breaks or break times or lunch times in between, whatever that it is. Apart from that, I'm picking up from what you said in more depth, how it was in my trust, and it still is that when you're working in a CT grade doctor, there is a window of, say, about 6 weeks where you're actually doing only on call. So you don't go to the wards. As a doctor, you don't get any theatre sessions, whether it's trauma or elective. All you do is on calls. Of course, you get adequate breaks. You get holidays in between. If you're working for 3 or 4 days, then you get a couple of days off. But there's a 6 week window where you're simply doing. You're the first orthopedic on call. You are the first person as a liaise for other departments, including the A&E. So if there's a patient in the A&E or the casualty that needs an orthopedic opinion, you will be the first person that will be contacted and required to make a decision as to what to do with that patient.
I think what it does is eventually it all averages out, whether you do it as a block, whether you do it as a regular daily work, but they're all designed in such a way that at the end of a certain amount of time, they all average out and no one ends up doing more work than you're supposed to.
The total number of hours would always remain neutral. And that's what happens. So if I'm doing on calls, I'll probably get more days off. And once my block of 6 week on calls end, that's the point where I get, then after that, they'll start posting me in the wards, once a week in the trauma theaters, where you go as a second assistant, obviously, because the consultant is there and there's a registrar working under him and you're there to support them.
Okay. So, I think that kind of covers what you're expected to do as an SHO. Again, I would like to say that this is from our experience. The experiences might vary for different people in different hospitals, depending on who they work with. But this is more or less what you're expected to do as an SHO. I would say that it is imperative for us to understand, for people who've done their postgrads back in India, who've done their MD, MS, they've worked as a senior resident for a while. Some people have even worked as a consultant, to come and do this ward work, be responsible for patients, and still not have a lot of surgical hands-on, or to be dealing with patients directly for those in the MMed pathway can be taxing mentally. It's not a trivial issue, but I think once you're mentally prepared, it's a very good way to learn the basic management of patients, to understand how the system works within the NHS. And I think what we have to do is you have to look at it from a point of learning and understand there's a lot that we don't know and that we can probably learn during this period.
Yeah, just to add on to that, I think just out of a personal opinion, what I would say is that the message that we are trying to convey here is that you really need to manage your expectations before you come in here. If you're thinking that you're going to come in here and you're going to and on week 2 or week 3 of you working here, they're going to let you go and start operating in any form. It's a far-fetched opinion, I would say, and you have to really and this goes on for a year. You have to believe that. So it's a major source of discontent for a lot of people. I have to mention that. So you have to really manage your expectations before you know that for a year these are the duties that you will be doing.
Fair enough. And what happens after the end of this 1 year is you lead up to an appraisal process, which is generally held somewhere towards the end of your first year. You generally have 2 appraisals, one within your hospital and the second with the WWL Trust. And this appraisal means you would go back and review with your appraiser, who might be your consultant or someone within your department generally, who would sit down with you and see all that you've learned, all that you've worked with. You're expected to do some audits and maybe work on research papers if you're interested. All these things add up as point-based system. You're also expected to, present these audits at meetings. These meetings can be held either monthly or quarterly, depending on, trust to trust. All these things eventually add up for the appraisal process. Also, during this time, a lot of people take up the time to give their MRCS. It's again, there is nothing to say that it is necessary or it is something which needs to be done, but it's an option that a lot of people do try to do it. And it's a good way to learn on safe surgical practices and ways to manage patients within this healthcare system.
Absolutely. It's a very effective way to understand and get your basics of general surgery very right there. And it's an important stepping stone to move ahead, especially if you're looking to move out of the MCH program in the long run.
Yeah. So once your appraisal process is done, mostly, I wouldn't say all, but it's very rare for someone within the MCH program or the MMed program not to rise up to the level of a registrar in the second year. Once you do rise up to the level of the registrar, you become a part of the registrar rolling rota, and this registrar rolling rota is the one which is for the specialist trainees, those who have entered the training generally. For orthopedics, this means 6 years of training starting from ST3. So you actually have CT1, CT2, and you go on to ST3 and then work up to ST8, which is around when you're expected to have cleared your FRCS, and you can then move on to seeking fellowships or applying for consultant jobs. So you essentially start off at an ST3 level when you're starting on the Reg Rota. This upgrade is important because your responsibilities change. You start working directly under a consultant or a team, again, depending on which hospital you work in. I worked as a part of a team. I think, Aditya, you work directly in a consultant.
So, I mean, Ekans was in a major trauma center. It's a big hospital, a lot of people coming in, huge orthopedic department, so they're part of a team. Mine was a district hospital, so slightly, I would say, different responsibilities, obviously. And I was working with my consultant. It was just one consultant and one registrar as a part of the team. And that's it. So it's a one-to-one basis, and there are pros and cons to that. The pros is that you get undivided attention. You've got a set of patients that you need to look after, and you're answerable to one consultant. So the learning process is a little more, a little closed, I would say. But obviously, in a major trauma center, you're working part of a team. You see more and more patients and more complex patients, and that's the advantage of going in a major trauma center as well.
There are pros and cons for either side. So either ways, as a registrar, your duties generally involve designated theatre sessions. Unlike when you were an SHO, you generally have a designated time, and this is generally with the consultant or with the team that you're supposed to be working with. How many theatre sessions you have a week depends on how often your consultants operate and how often the lists are, how busy the workload is. Again, something which can vary from hospital to hospital. Besides doing designated theatre sessions, you're also expected to do designated elective clinic sessions. These essentially equate to the OPDs or the outpatient department that we had back in India. This generally, again, pertains to the subspecialty that you're working in. So say, per se, if you're working with spines, you would generally be working in clinics which deal with spinal patients. If it's hip and knee, you'd be working with patients with hip and knee arthroplasties, and so on and so forth. Besides working with the clinics and the theatres, you're also expected to do the on-calls as you were doing while on the SHOs. But what does change is when you're on call as a registrar, you also have an SHO to help you out, which actually helps quite a bit, I think.
Yeah, and of course there's other aspects to it as well, because for example, I'm working in a district hospital, so at my hospital the registrars get it off easier in terms of the on-calls, because they don't necessarily have to be on site and have to be available on the phone, whereas the SHO manages everything all by themselves, obviously, at the hospital, and that's the only person you have in the entire department in the hospital who has to look after the primary referrals from any sick patients in the ward, and obviously if they need help, they escalate to us and then we have to step in.
Yeah. So I think this kind of covers what duties we're expected to do as an SHO and as a registrar. I'd like to highlight the fact that these are things that we've picked up during our experiences. The experience may vary for different people in different trusts.
Yeah, absolutely. I mean, there's always all these things will vary according to the consultant that you work with.
Absolutely.
Essentially, what we just do as a registrar is mimic our consultants' rota and their job plan, and we learn from them along the way.
So I think just to make it simpler, you think of SHO as a non-acad JR post, and you think of as a registrar as when you're working as a junior resident or as a postgraduate in India. Yeah. That's possibly the easiest way to try and understand this. I'd just like to say that we've tried to give you in a consolidated form, in an assimilated form, what we've picked up in our time here. If you've missed out on something, we would be more than happy to clear any doubts or
Yeah. If you have any questions, you can email us that we've mentioned, or you can post it in the comments down there.
And we'll put our email addresses up there, so feel free to reach out to us. More than happy. And we'll be coming back to you with more videos, and hopefully you like them and it helps you, and prepare
yourself to come to the UK.
Maybe see you in UK.
Yeah.
All right.
All right.
Thank you, guys.